Misinformation is being widely shared about the vaccine. So please make sure to always check and use only reliable sources, such as the Centers for Disease Control and Prevention, to get accurate information and to dispel these myths. The COVID-19 vaccine is a 2-dose series given either 21 days or 28 days apart, depending on the brand you get. While it takes 2 weeks for your body to provide protection after you get the vaccine, both the Moderna and Pfizer vaccines are safe and highly effective at preventing disease. The vaccines are around 95% effective at preventing a person from getting COVID-19 after you've received your second dose. Eventually, everyone will be able to get a COVID-19 vaccine if they want one, but it'll take some time. Priority groups are set by the Ohio Department of Health in a phased rollout, protecting those most at risk in order to save lives. As more vaccines become available, more tiers will be added by the Ohio Department of Health. When your priority group is open up, you will be able to be vaccinated at one of Columbus Public Health's drive-through vaccination clinics, your healthcare provider, or retail pharmacy outlet.
Welcome to ROAR, our roundtable on actions against racism. I'm Dr. Darrell Gray, a physician, researcher, and community advocate, and I'm honored to moderate this, the second in our series of roundtables. Through the looking glass of COVID-19, we've seen the direct and indirect impacts of racism on the health of our families, peers, and communities. The disproportionate burden of this has been among communities of color. This must change. The health of our nation is dependent on how we treat those who have been made vulnerable by systemic inequity. The health of our nation depends on us moving closer towards health equity. There are glimmers of hope. We've seen new partnerships emerge in trying to tackle health disparities and the upstream social determinants of health that present barriers to wellness. Recently, one of my colleagues, Dr. Joshua Joseph, led the publication of a paper that describes a novel academic community government partnership that enabled the distribution of 46,000 face masks, 10,000 soaps, 18,000 hand sanitizers, and 12,000 dental hygiene items in high need areas across Franklin County, Ohio, in early May after the first surge of COVID-19. Such partnerships are critical to another glimmer of hope: vaccines. Vaccines against COVID-19 are being distributed across our nation. I personally have received both doses of the Moderna vaccine. However, as we look at the data, there are many who are eligible based on Ohio's phased approach who haven't received a vaccine. And as we look closer, we see that many of those are within communities of color and low income and high social vulnerability areas. And many headlines attribute this to mistrust. However, I think that places a lot of blame on communities and fails to acknowledge the history of us in medicine and frankly science of not being trustworthy. Now is the time for restorative justice. We can beat COVID-19, we can be equitable in our distribution of vaccines. It will take all of us to accomplish this. That brings us to our roundtable today. We have an amazing group of panelists here to share their perspectives on barriers and how we can move forward. Let me introduce them to you. We have the pleasure of having Dr. Sue Kolatar, Director of the Division of Infectious Disease here at The Ohio State University Wexner Medical Center. We have the pleasure of having Pastor Keith Troy, pastor of New Salem Baptist Church. We have Dr. Celestia Aspa, founder and president of Ethiopian Tewahedo Social Services. And we have our own Columbus Public Health Commissioner, Dr. Maishika Roberts. With that, I'd like to begin and dig right into our conversation today. And I encourage you all, as you come up, as you hear this, as you have questions, please enter them into the chat using the Q&A function. We will be reviewing those, and we may not be able to get to your question, but we see you, we hear you, we thank you for being here. We have people who are participating from all over the nation. This is not just a Columbus conversation. This is a nation conversation, and we thank you for being here with us. We also welcome your feedback, so be sure to give us feedback. At the end of this, we'll share a link by which you can share your feedback. And again, please use the Q&A function. Will have an open Q&A toward the end of this program. Now I'm going to turn to you, Dr. Kolatar. The disproportionate impact of COVID-19 on communities of color has been the narrative since the first surge in early 2020. And now we have vaccines. We're administering them in a phased approach on the verge of widespread community distribution. However, some in our community are having difficulty in deciphering what's misinformation and what's truth. Additionally, some are hesitant to accept the vaccine and attribute some of that to not knowing, what's happened with it being developed so quickly. And layer on top of that what I mentioned just a minute ago about the history of mistrust and, frankly, medicine and science not necessarily being trustworthy, and there being a lot of trauma from that. So would you please just take 3 to 5 minutes, kind of walk us through the vaccine and what are these myths and misinformation that you see out there that you'd like to help us clear up?
Great. Well, thanks so much for the invitation to do this. I'm quite honored. I think one of the questions about trust is always how much information is shared and how transparently. And before I talk specifically about the vaccine, I really want to talk for a minute about how clinical trials are done. Usually there's something way before things happen in people, things in the lab, in animals. And so the whole COVID-19 pandemic, which has only really been around for about a year, but seems like a lifetime, really seems like things have moved really, really quickly. So after you identify something, and in this case, a vaccine, how does that happen to get to the place where it's being given to actual people? And there are phases of clinical trials. Phase 1 are usually safety. They're usually relatively small, less around 100 or so people. They usually last a year or so. Phase 2 is a little bit bigger, still focusing on safety, but really looking to see how effective whatever the intervention is. Phase 3 are the bigger trials, usually thousands of people, sometimes go on for years before we get an answer to a question. And then phase 4 is after drugs are approved, which are post-marketing. So I really want to have people understand and want to emphasize this point that all those phases happened in these clinical trials. The timeline was compressed, but they didn't skip any steps. So I think I really want to emphasize the safety of these trials. How did that happen that they could be so compressed? Well, first of all, COVID-19 is a pandemic. It's a worldwide problem, and there's lots of disease out there. And so trying to find something that would prevent that was easy as we were looking for disease. Number 2, the trials were big. There were 40,000 people in the Pfizer trial. There were 30,000 people in the Moderna trial, and the enrollment was very rapid. And so we were able to get answers very, very, very quickly. And even before all that happened, I want to say that the technology to develop these vaccines, these mRNA vaccines in this case, have really been in place for about 20 years or so. There's not been a lot of talk about them. They've been looked at for different other viral illnesses, Ebola, you may have heard of, even influenza. So that was all in place. And the important thing about the rapidity as data was being collected quickly was that the manufacturers were also manufacturing these vaccines. And so not were they available just for the trials, but ready to move forward. Because there was a lot of confidence that they would work. And I think you all may have listened to the video that Dr. Roberts did. The vaccines are very effective. And I believe they're very safe. And like Dr. Gray, I just had my second shot last week as well. So I don't know if that completely answered your question, Daryl. But
yeah, it does. And can you also speak to the representation in the trials? Because one of the things that really struck me that was a good thing is that as we looked at those who participate in the trials, we got close to the representation of what it looks like in the United States. I think about those who are Black, and we represent 13% of the population. And they got close to that in these trials. Any thoughts from you?
Yeah, I think great question. I think all the trials have really tried very hard, and appropriately so, to include all the populations who are infected. And when you think about that, that's basically the world. And so we should reflect the population of the world. not the trials, not the vaccines that are currently available, the Moderna and Pfizer, but the AstraZeneca trial, which we actually did here at Ohio State, was very focused on that. And I'm incredibly proud of my team to say that our enrollment of minorities was higher than our enrollment of the white population. So I'm thrilled about that. And I think, I hope to continue that. We've always been committed to trying to enroll representative populations. So yeah, I think that's a good thing. Because that is one of the questions people say, why would I want to do this when people like me weren't in the trial?
And Sue, you've been at this for a while. I mean, I'm not trying to date you, but you've been on the front lines going back to the AIDS epidemic, and you've seen, issues with mistrust, and again, our kind of not being trustworthy over time, and how we've tried to build relationships and be better with our community engagement over time. What lessons kind of have you learned over the years about building trust, particularly in Black and brown communities, and that have been disproportionately impacted, in this case by COVID-19? We can go on about other diseases and other areas of impact, and what we can learn from that we can use now as we're trying to distribute vaccines, and also just get education out there.
Right. Yeah. Thank you. Yes, I've been doing this for a long time, 30 plus years, and actually with a different epidemic virus, HIV, which I think has really taught us so much, and there's another reason why the field has been able to move forward so rapidly. The things we knew about viruses, the things we knew about our immune system, really have built on much of what we learned in the HIV world. But I think for me, the important thing has been communication of and transparency of how things are being done, of results, of the importance. But probably even more important than that is, in terms of communication, is communication on the other end, really listening, right? I think we really have to spend time listening to what people say and how they respond, and sometimes even to not what they're saying. And how do you build those relationships and trust, I think is probably the key feature that has really driven me in terms of, and my team in terms of people in trials.
Yeah, I think that's so important. I'll tell you, like many other people who are in the healthcare space, whether they're a physician or not, family members often rely on us to provide that information. And, I'll tell you, I can't tell you the number of text messages, emails, phone calls I've gotten, not only just from family, but from kind of extended family. Like I grew up in Baltimore, Maryland. And so the home church I grew up with there wanted to coordinate a kind of Zoom conversation or phone conversation to talk about it, because these concerns are real. And, on that conversation was brought up the Tuskegee syphilis experience. Yeah. And I mean, we are now in 2021, but, this is not, Tuskegee syphilis experience is not forgotten.
Yeah, no, absolutely. And I think that's so important for us to remember. And I think the other thing I would like to say is that it's important for us as we try to educate all of ourselves, even, that we include our patients and our people to do that. The most gratifying thing about having done one of the vaccine trials here now for me has been the people who have participated in it, who've told me not just they're doing it for themselves, but they're doing it for their community, and how we engage that, I think is critically important. And as I said, and as you said, I've been doing this a long time. So I just want to publicly acknowledge anybody who's ever participated in a clinical trial. It's why we've made a difference in science.
Well, thank you, Sue. I'm going to circle back to you in a moment, but I want to go to Pastor Troy. Again, thank you, Pastor Troy, for joining us. Now, you lead one of the largest congregations, particularly of African Americans in Columbus, and you've seen how racism has impacted our economy, income inequality, safety, health. We've seen how it's impacted Black and brown communities more tragically. As a pastor, you see firsthand as you comfort your congregants. You've lost loved ones. They have too. As they work with their families and you work with their families, you've seen people who've lost jobs. Tell us, how have you kind of navigated this? What role do you see churches playing in helping to educate and enlighten and encourage our community about protecting ourselves against this potentially deadly virus?
Dr. Gray, good afternoon, and thank you for this opportunity to be able to share. I think as a church, we've always taken a holistic approach to educate, encourage, and enlighten our community. Most recently, through our own community foundation, we established a social justice empowerment council whose work really falls in three buckets: awareness, advocacy, and action. Within the context of our discussion today, the church's role in dealing with this virus and support various health and education initiatives, it's our role to lead in those endeavors and to try to make sure we bridge the gap from those that we serve in our churches and the wider community. So we are a bridge builder in terms of those kinds of things.
And can you tell us a little bit, for those of who are watching who don't know about the demographics of the population that is the New Salem Baptist Church, can you tell us a little bit more about your congregation, kind of where they live, their age range, and the people you're seeing?
We are located in Northeast Columbus, Ohio, more importantly, North Linden area. In terms of that, we have been up there for 30 plus years, coming from the Near East Side. Our congregation is a hodgepodge of some of everyone and everybody, from those who come out of the deep roots of Linden to those who live in suburbs, to OSU professors, to OSU students, to those who've never been able to go to OSU. So basically, we kind of service a little bit of everybody, and we're surrounded by a community that's in tremendous need. We have identified a 5-block area around the church that we serve. We call it the Golden Triangle. But for instance, in those 5 blocks, there are 22 vacant houses in those 5 blocks. So we see the reality of the best and the worst, not only on Sundays, but during the week as well.
Thank you for that. Now, given the history of distrust in the medical community among people of color, what role can the church play in building bridges and addressing the kind of chasm between the medical and these communities of color?
We've established for some time now, when the pandemic hit, we went into a phase called Wellness Wednesday for the church and the community, where we were able to engage our professionals to be able to have conversations with our community around health and wellness. Recently, probably about 2 weeks ago, we were able to engage 4 of our doctors because of the concerns and issues being raised by our congregation and the community. And those 4 doctors were able to answer questions and give information regarding the pandemic, the trust and mistrust. And we were happy. Dr. Benita Ward, Dr. Earl Haley, Dr. Eric Ward, and also Dr. Chris Brown. And so what it was able to do was help our folks, even if they distrust the science, was to trust the scientists. And because they had relationships with those folks and saw those folks from Sunday and able to engage, it was a very convincing conversation, to the point where after we did the Wellness Wednesday, several of my members texted and emailed me and said because of that, they were willing now to give serious consideration and take the vaccination, where before they had doubts and concerns. I think you've got to put people in place that they can relate to and they believe and trust.
And before I head to Dr. Celestia Aspel, I want to ask you one last question. I'm going to put you on the spot, Pastor. Do you plan on getting the vaccine? And if so, is that important to you and your family?
If you do, who I lived with and been married to, that question, you would already know the answer to that. Most definitely, we do plan on getting the vaccination as soon as our time frame becomes up. I'm happy to report that both my parents, who are 94, have already received the first phase of vaccination, and our plan is to make sure they get the second phase. So yes, we do plan to do it. We have medical professionals in the family. More importantly, want to be around for the grandkids. And so if even not for me, it's for those who are coming behind. And so yes, we're excited about those opportunities.
Thank you, Pastor Troy. I'm going to circle back to you in a little bit. Dr. Celestia, your work with New Americans, immigrants, and refugees is long and deep. And is an example, honestly, for the nation. We've worked on several projects together. I had the pleasure of also, in full disclosure, serving on your board. And I know that COVID-19 is a real concern amongst New Americans. Can you share your thoughts on how racism and COVID-19 have impacted New American communities?
Thank you, Dr. Gray, and thank you, the Wexler Medical Center. And it's an honor to sit in this Zoom meeting with Pastor Troy and Dr. Coltar, Dr. Roberts, and to share my perspective from the New Americans aspect. Yes, we are fortunate, Columbus, Franklin County. We have so many diverse groups, nations, and nationalities, over 120 languages spoken here. As you know, that diversity is strong city. And really, we appreciate that to include us in this kind of conversations. That's what, the city of inclusiveness and diversity, that tells me that how really our institutions, the city or county embracing us. Yes, the new Americans, as you know, the COVID crisis hurting all our communities, but not equally. It is already clear that communities of color, refugee and immigrants are again on the front line of vulnerability. Because, when I say front line, especially the refugee immigrant community, they are the workers at the front. If you go to the home, healthcare, the healthcare industry, the food industry, the manufacturing industry, our communities are at the front line. And even they are overrepresented in the home care area. They are the first to be hard hit by the COVID-19 pandemic. And as you know, racism is a root cause of all disparities, whether it's health crisis, economic crisis, it is there intertwined. I mean, we cannot separate them. One effect is other impact. So they lost their jobs, they lost their loved ones, their families. And we heard from the community leaders that 3 to 4 days per week here in Central Ohio. So that was really very devastating. The challenge and the impact that makes for our community is that, especially, grieving and mourning in our culture is really, you have to stay for a week, for 2 weeks together. And it was hard for us really even to build awareness because in the initial phase of the virus, our refugee immigrant understanding of the virus was really very low. They said, oh no, we are refugees, we're hard, we have gone through all kind of hardships, the virus will not touch us. And there was one example that I'll share with you from Columbus. There was someone died in Cincinnati. The whole family, about 15, went there to mourn and grieve together for a week. When they returned back, all of them became positive. That was, it's a blessing in disguise. It gives us really an opportunity for us. Now the community understand that the virus was serious. Since then, I think, all the measures that we do, the awareness and the PPT distribution was easy for us. But the challenge is still the culture plays a role, the language plays a role. And also, we are good, different institutions providing, language translation, interpretation. But that piece of cultural interpretation is missing. Because these people, they want someone whom they trust to tell them the truth. That was really some of the factors that it was affecting our community, especially that what hard hit was the small businesses of new Americans. It's really devastating. There is a lot of restaurants, ethnic-based stores rely on their community. After the epidemic becomes more and more, everybody stays at home, and and most of them, they lost their job. And really, the hardest hit in our community are our new American small businesses, and especially our women lost their jobs, which is really because naturally in our culture, moms have to stay at home. They are caring good on the children, and because of that, they really most of the job loss that we have seen is in our women's. So that's really very because without women, bringing breads to their house, to the challenge, and also applying for unemployment. And it was a hard time, and to bring them back to the workforce. I mean, my staff and all the refugee immigrant serving organizations tried the best that they can, but it was really the hardest part in our community because that kind of reluctant that the virus will not hurt us, and then the misinformation about in the initial phase again, the virus is not hurting us, kind of things, and hurting us. So I think the new Americans contribute a lot, but that was, how it's really devastating in our community.
And Dr. Celestia, you mentioned the community, but many may look at ETSS and have misperceived that ETSS only serves Ethiopians. Can you please comment on the communities that ETSS serves and the new Americans you're referring to? What different communities are represented?
Yes, thank you, Dr. Gray. Yeah, initially, because they see our name Ethiopian, people, they think that only that we're serving Ethiopian, because I'm from Ethiopia. I'm the founding member of the organization initially in 2005. In 2000, when we started the organization, was focusing on the Ethiopians. But since 2005, we opened the door for all. And we serve about 57 countries here in Central Ohio. We have about 13 locations throughout Central Ohio. 3 of them are community centers where we provide, because access to services to our clients is so important, so that each site is represent peculiar communities. Like the Northeast is mainly for the Somalis, the North is for the Bhutanese, Nepalis, and the far North is for Burmese and West Africans. The East Center is usually Ethiopians and Eritreans. So we have only one center for the Ethiopians and Eritreans, and Whitehall area is most, Hispanics and again, the Ethiopian, Eritrean, that area. The West Side is focusing on Mai, Somali Mai and Somalis and the Hispanics. So very much, we have these diverse groups that we are serving, especially in this COVID-19. We reorganized our structure, the COVID-19 strategic response team, where the different community liaisons, bilinguals, community managers come together, so that because we have structure at the root level, in the family level, so that easily information is spread out there, and then we retrieve that information back to us, and in partnership with Columbus City School, the Columbus Public Health, Franklin County Public Health, we share that information, we get information from them. So that's what we try to spread out the information to make sure that our new Americans can be saved and get resources and support that we are looking for.
And Dr. Seleshi, before I go to Dr. Roberts, I want to ask you one final question. What can we do? Certainly, you've had a good collaboration with OSU, but just the larger medical community, what can we do to better engage and educate our new American communities?
I think my recommendation is, as I said before, the cultural interpretation is very important. It's good to use the media outlets of refugee immigrants, because that's what, our needs are different from the general public. And interventions that are designed mostly is towards the general public and left out the specific needs that like the refugees and immigrants. So, yes, it's good to have those news and, on TV and Twitters and all those kind of things, but there are social media or media outlets of refugee immigrants. It is really good to use those so that easily they can access the information. And second is, I think it is good to collaborate with our unsung heroes, individual community leaders that working hard day and night. It is good to partner and collaborate. I'll say this the good example that we have the Wake Center Medical Center for mammograms testing in the Northern land. Even last week they came and they did in this pandemic time. And another good example that I would like to mention is the Central Ohio Health Map 2022. I'm part of in that group. The hospital system, the 2 health departments, and some community-based organizations, they do a health needs assessment for Central Ohio, which is really a good example. So I think the hospital system, if we collaborate, even for example, we try to get data of how many based on country of origin, how many people are affected or days from the new Americans. We couldn't find. We asked the coroner office, the health department, we couldn't find any. In general, they're lumped up either African American or Asian American. It's really difficult for us to get that information and to make a designed intervention for our community. So I think collaboration is the best modality that the health systems, and we can be already the infrastructure is there. We know the culture. Our organization alone speak about more than 30 languages in ETSS. So you can use that kind of infrastructure rather than inventing the wheel. And then third is that I think it's good to give an implicit bias training for all your health workers about the cultural competency, about the mistrust, about racism. I think that will be a good understanding so that people knows the cultural differences, what were, in the community.
Thank you so much, Dr. Seleshi. We're going to come back to you. I'm going to circle to Dr. Roberts now. Dr. Roberts, you're no stranger to providing care to those made vulnerable by systemic inequity. Community, when you talk to people about the COVID-19 vaccine?
Well, thanks for having me, Dr. Gray, and I'm happy to be joined by others on the panel today. You know, what I'm hearing and seeing is exactly what some have already acknowledged, is there's this mistrust for our healthcare system. People don't understand how this vaccine was created so quickly. And they question, is it safe and effective? And they go back to history that Black and Brown individuals have had poor experiences with the healthcare field, whether it be the Tuskegee syphilis experiment, whether it be Henrietta Lacks. There's a lot of misinformation and a lot of mistrust out there that we have to first acknowledge, and then we have to address and explain why this is different. And so many people are reluctant to get the vaccine because they think it was done too quickly, and they think there's too much we don't know about the vaccine. And to some extent, they're right. There are still a lot of unanswered questions about this vaccine. The most obvious is, how often do we have to take this vaccine? And we don't know the answer to that yet. But what I try to tell people is, if you get sick with COVID, you have no idea of knowing whether you're going to be one of those people that have relatively mild symptoms or one of those individuals that have severe symptoms and end up on a ventilator to help you to breathe. And then you could be one of those small percentage, but yet there exists people who lose their life to COVID-19. So a lot of people are also questioning what's in the vaccine. And I was talking to a scientist the other day, and he brought up the question, how many people ask what's in the potato chips they eat? You know, and that's a valid question. I realize it's different, but it's a valid question. We consume things every day, and we don't often ask and question what's in this. And so the vaccine doesn't have egg products, it doesn't have pork products, it doesn't have human remains, and it doesn't have fetal remains. But those are some of the things that we're hearing that could be in the vaccine, the misinformation that's out there. We also hear that it could have tracking mechanisms in it. If you get the vaccine, the government could track you. Well, that's not true. If the government really wanted to track all of us, they could by just the use of our smartphones. We all use smartphones all the time. And that would be a much more effective way for the government to track us than any vaccine. But there's definitely a lot of reluctance, and there's more reluctance in the minority community. I mean, my own mom, who is a nurse, when there was talk about the vaccine, at first she's like, I don't know if I'm going to get that vaccine. And, you know, I asked her the question, well, why? And she said, I just don't know. I don't trust it. And some people think the government had their hands too, they were too involved with the process. And the previous administration, there was a lot of mistrust for that administration. So that made people concerned. But when I asked my mom, would you rather get the vaccine and deal with whatever side effects may come from that, which are minimal, or would you rather take the chance and get the infection and get really sick? And when I asked her that, she's like, well, that's a no-brainer. I want the vaccine. And so fortunately, her turn came up and she got the vaccine. But, you know, she's a nurse. She's married. She was married to a doctor. My father's a doctor. I'm a doctor, and she was reluctant to get it. So, but, you know, to Pastor Troy's point, hearing from people that you trust and value their opinion, I think makes a big difference in getting people to think differently about whether or not they'll roll up their sleeves and get the vaccine.
We talk about trust. That's been a theme. Where does racism fit in all of this? And what can we do to overcome this?
Well, as we all know, racism is alive and well in our community and across the country. But, you know, what can we do? Again, acknowledging it. There was discussion about cultural competency with healthcare training, with healthcare providers. Most healthcare providers in Columbus have gone through some level of cultural competence training. But, you know, it exists. It's not right. And we, as individuals who have been impacted by racism, unfortunately have to do a little extra work sometimes to advocate for ourselves. And so I recently told a story. One of the first cases of COVID-19 we had here in Columbus was a person of color who sought healthcare at one of our local ERs. had some risk factors at the time. The individual had traveled, and when they sought care for COVID-19 or for their symptoms, they were told they were not going to get tested for COVID-19. Now, at that point in time, we had very little testing being done, and you had to, meet a lot of different qualifications in order to get a test done on you. This individual had to literally beg his care providers to get him tested. And fortunately, one of his care providers listened and convinced the provider, the physician, to get this individual tested. And the individual came back positive. And so I say that only to say that we all have to advocate for ourselves, no matter what color you are. But when we are a minority, we often have to do a little more advocating for ourselves or for our loved ones, particularly in the healthcare arena. And is that right? Is that the right thing? Is that the fair thing to do? No, it's not right, but it's what we must do in order to make sure we get the best care that we can. So I think, when we think about racism, when we think about healthcare, one, I would just say we have to acknowledge that racism exists. Two, we have to educate ourselves to be knowledgeable. We have to advocate for ourselves. And, someone else said something, I heard someone say, I've had a bad experience with healthcare. I was mistreated the last time I went to the ER, so I'm not getting the vaccine. Well, those two don't really go together. Just because you've had a bad experience at a healthcare provider or a few healthcare providers, why are you going to deny yourself the ability to get this potentially life-saving vaccine that can not only protect you, but those around you? And so someone said, yeah, I've had food poisoning before, but I keep eating food. So again, good examples. You've had bad experiences with things in the past, but that didn't stop you from going back to seek care or to seek that joy of eating food. So I think those are things we all need to think about, is we can't let the racist experiences we might have had deny us this opportunity to get a life-saving vaccine.
And as we transition to the next component of our program, where we transition to action items, and I'm going to ask that Bartha, our technical assistants, will get all of our speakers back on the screen as we transition to this part. I want to build upon this piece because I do agree. I do think that there is advocacy in there. I also think that we have to be able to translate the stories, which are these kind of advocacy pieces where, whether it's from a patient in the emergency department or a learner experience has had, even within our own walls, had a bad experience, or one of our employees or folks who are in the community who have racist encounters. I think we have to, as just a global community, society, certainly as a health enterprise, more readily and quickly translate these stories into strategies and systems so they do not happen again. And I think that we can do that. I think it requires not only advocacy from people who have a lived experience in this realm, but certainly it requires those in power, those who often and those who are in power, for whether it be community organizations, whether it be business organizations, whether it be healthcare enterprises, who don't look like us or who don't have that lived experience, but are in power to enact change, whether that be in policies, practices, and funding and resources to create change. I strongly believe we can do it. It is, like you said so eloquently, it is not right. And we have to put strategies and systems in place to navigate that. And that takes us to kind of our next piece. And really, Dr. Kolatar, I'm going to start with you. We're certainly going to circle around to all of our guests before we open up the Q&A to all of our attendees today. But I want to start with you again, as Bartha is going to help us get all the speakers onto the screen, kind of Brady Bunch Square style. But Dr. Kolatar, can you share with us kind of what you can commit to, your division or even OSU can commit to, as far as driving education, outreach, and engagement in regards to the importance of not only practicing safe COVID-19 protocols, but also trying to engage more around uptake of the vaccine?
So thanks, Daryl. So first of all, I found this discussion so personally enlightening, because I think I have not experienced some of the things that some of the panelists have experienced. And I think I'll go back to communication. It's acknowledging the issue at hand. It's building relationships. It's listening. And I think I would hope that I and my division and the university, probably the world, would just step back and take a deep breath, and when we're confronted with individual situations, really address them in a timely manner, not letting things fester, but really say this, this, in Dr. Roberts' sage words, this isn't right. And I think that's what we really, really have to do. And I would be honored if some of that relationship building could start with the panelists now. I mean, a couple of you I've known for a while, but like Pastor Troy and Dr. Saleshi, I would love to I would love to commit to doing more. I will make one final comment. I commented about some of the participants in our trials, and I am committed to taking advantage of some of those relationships, because I've offered to all of those people who've said they are doing it for their community, even though their community was suspect of their participation. So I think we need to get the word out there. And the final thing I will say is that we have to be honest. We have to be honest about the things we know, and we have to be honest about the things we don't know.
Thank you, Sue. Pastor Troy, I'm going to bring you back in. Really, if you can share with us some things that you think New Salem or you as a pastor can commit to with really creating spaces of understanding between the medical community and your congregates, and honestly, the broader community around these issues.
I think for us is to continue trying to find out information and best practices, and not only with our congregation, but sharing it with our other church families and pastors and religious leaders throughout the community. We try not to do anything that's not replicatable, regardless of size. And so as we come upon information, we certainly want to make sure we share it with others who are in leadership position. As well as another thing that we have committed to personally is the whole endeavor into the whole mental health piece of this. A lot of times we talk about the physical aspects. We are blessed with some outstanding mental health professionals in the congregation. So we're challenging them as well as our congregation to say, okay, how do we deal with this whole issue from a mental health point of view, whether that's the seniors in our congregation or our young people or young families. So we're excited about those possibilities. And our commitment is also to continue to provide fresh fruit, food, produce, those kinds of things that we do through our food pantry. It's amazing to me to see how many people are still struggling with just having the decent things to put a meal together. And every Wednesday and Friday, we see that ongoingly. We see diversity in our community and that food pantry that we may not see in our churches. So it's amazing to see needs can be met. We're excited about to continue to do that and help other congregations to do the same thing.
Thank you. And Dr. Roberts, as we prepare to open up for a broader Q&A, I want to ask you, what about you, Dr. Roberts, and Columbus Public Health in regards to whether it be getting folks out to get vaccinated, or not sure getting folks out, but even going to folks to provide vaccination, but also just better trust from our standpoint as a community, needing to be better trusted brokers to the broader community?
Yeah, so thanks for that. So one of the things that I've challenged my team with, and we are doing, is we're taking 20% of the vaccine we get every week, and we are going out into vulnerable communities and providing that vaccine to those communities that are hard to reach. So we're using the CDC's Social Vulnerability Index to determine those zip codes that we need to go to, which pretty much align with our opportunity neighborhoods or our Celebrate One neighborhoods. And thus far, this is our second week of doing it now. We vaccinated 505 people at the community level. And so, we've been taking it to low-income senior housing facilities, obviously staying within the phases that the governor has outlined for us. But it is our way of bringing it to those communities that are vulnerable and at risk and may not be able to easily get to us at the fairgrounds where we're offering the vaccine. It's still my public health nurses. I'm not changing anything about the standard of care and how we provide that vaccine. We're just making it more accessible to those individuals.
Thank you. Thank you all for that. We're going to start opening up to some questions. One that came across, and this is open to anyone who wishes to answer, is, where do we start? as we think about some of the challenges we've discussed today, the groups that we need to reach, where do we start? What's the first step in kind of getting us to where we want to be? And anybody can chime in.
Well, Dr. Gray, you and I have talked about this, and it's a bit overwhelming when you think about all the people out there that you want to reach and provide this basic information to help them make the decision that's best for them and their family, and to really dispel some of those myths. And so I think you start with the basics. You start with those around you, talking to people around you, your family, your friends, your neighbors. And I think as an individual, something that we can all do, but particularly those who have questions about the vaccine, is educate yourself. Going to trusted resources, whether that be online or people in your life that can give you the right information, is important.
Thank you. Yes, Dr. Saleshi, go ahead.
Yes, I think the first step is change has to come from self-education, and I'm planning to
and then think big from there.
Okay, so I already started to train my leadership about race, equity, and justice. Dr. Gray, we're planning to do that. It starts from the leadership, and then the whole staff to be equipped to understand the basics of racism and about the vaccine distribution, about COVID-19, so that we start to really make our infrastructure to be ready for that. And then to strengthen our New Americans Community Leaders Collaborative, where it's composed of grassroots community leaders who are building their capacity. We got, fortunately, a fund from Momentum Fund, which is a Gates Foundation, to build the capacity to empower these organizations, and then give some seed money to do their outreach and build their capacity. So that's really a good momentum that we are building in, because empowering these community leaders means empowering our community. So that is what we are planning, and we are heading toward this. And then third is really to join the call to action movement. Nowadays, there is a call for justice, for equity, and racism and movement, so that I am committed in my organization to join that call to action movement.
Thank you so much for that. I'm going to merge a couple of questions into one. And really the themes of these questions are communication. One is from the stance of someone who is white, who wants, or working within a predominantly white organization, who wants to help with communities who are not white, and how can they be more engaged in validating truths and dispelling myths? That's one piece. The other piece is around communication to our elderly and those with disabilities. How can we be better at that? So a two-part question. Anybody wish to start?
I think for me to try to answer that is what I have shared with many of my white colleagues is to treat people like you treat your own children or your own family. And where you see wrong, stand up to it. Racism at the end of the day is sin. There's no ifs and buts about that. And in our profession, we are charged to combat and deal with sin. And if you're an advocate, be an advocate. I think there can be those who are out front, but there are also many who can have the backdoor conversations. A lot of conversations I've had have not been out publicly, but been with the powers to be, to say, how do we address this in a productive way, in a long-term way? I'm not looking for a quick solution. I'm looking for a long-term solution. So we have to be ready to engage in those conversations and hear the hard truths. I think to many of my white counterparts, they have to learn to listen. And sometimes that's not easy. And to hear the hard truths and understand the pain that people come with and the suspicion. That's why I think it's important to establish a relationship with people who people trust. I'm blessed every week, in some respects, to have a political forum, and I don't have to send out notices. And so we can use the influences that we have. I don't have to call for a meeting. It's there. And to effect those kind of changes based upon that, and I think people follow as they see us trust and engage. It's a respect issue.
That's powerful.
can I add to that and say, I think it's important for everyone to reach out, because it's already been mentioned. This is a very grassroots change. We're not going to make some global proclamation that there be no more racism. I think we have to be. It's almost in a way like herd immunity, right? As more and more people are educated and accepting and open and communicating, there's less chance for misinformation or being misconstrued. And so I think reaching out is key, and I hope to be able to continue to do that.
And what about our seniors and those living with disabilities? Are there things that we can do better about engaging them and make sure that they're aware, that they get vaccinated as well, that we kind of navigate processes to enable them?
I personally think that's a very labor intensive issue, right? I mean, I won't malign seniors as being less technically savvy, but so much of the world is information is distributed online or on Twitter or whatever. I mean, I think it's going to take effort to go engage families, to go be with their loved ones and have trusted companions with them, and go to people. I think we have to meet people where they are.
Yeah, I think the seniors are the most affected, traumatized, and especially with this COVID-19, there is a lot of fear and just not really comfortable. So it is the families who really is going to take care of them, and then friends, the seniors to seniors, to talk about. They talk over the phone, and nowadays, especially this connection with this COVID-19, it's very, very hard to bring, to talk with friends. But at least, they can talk over the phone, or the children can set up, video conferencing kind of things, because they don't have any outlet to talk about what is going on. The other thing is with any or others is a conversation is we have to break that fear, the wall of fear that, it's just a fear politics that really aparts us, and education, different forums and activities is going to help them so that, we can understand. It's just, if we are humble and, lead the conversation with humility, we can understand. We are all humans. It's just that politics of race and it makes us, that divide. There is nothing. We have to think really globally, and as a human race as a whole, and it will be really okay. But that fear is what is really people are struggling now. They just, once they are in their mind, they follow the same channels, and they cannot listen to others. They have to wear what the glass that I am wearing, so that they can see. Because if I have a black glass, always I may see black, but sometimes we have to change those glasses and see the reality.
Thank you
Dr.
very
Gray,
much.
I also
Please.
think that the piece that we saw on the news with Mrs. Catherine Willis, who's one of the resident seniors in Columbus, spoke a lot to our senior population, as well as those of us who take care of seniors. She's been on the battlefield a long time, and the fact that I think seniors could see another senior, and her testimony about why she did it and the importance of it was relatable. And I think the more examples of that you see, the easier it's going to be to communicate with our seniors and the families who are responsible for taking care of them.
Thank you so much. We're getting down to the last couple of minutes, and this is such a rich discussion. Honestly, we could be all day together, and I look forward to engaging with each of you. I want to give you the opportunity to give some closing comments, and I ask that we keep the comments brief, but I do want to give the opportunity. I'm going to start with Dr. Roberts, but I do want to give everyone the opportunity to give some closing comments and realize that, you're speaking to people in Ohio, but also those outside of Ohio. You're speaking to seniors, you're speaking to students, you're speaking to patients, you're speaking to employees, you're speaking to doctors, healthcare workers, nurses, technicians. But please, Dr. Roberts.
Sure. Well, just a reminder to everyone that we are all living through unprecedented times. We are living through a pandemic. We have unrest within our own country. We have racism in every aspect of our communities. And it's a very difficult time for our physical health as well as our mental health. I will say that it's important that we take care of ourselves, we take care of our loved ones, and that does involve protecting your family and yourself from the COVID-19 virus. And there's one tool that we have. There are multiple tools out there, but there's a vaccine that we have now And I would encourage you to strongly look into it and consider getting that vaccine when your term becomes available. I think it's important for you to do your homework now, because when your term becomes available to get the vaccine, you might not have a lot of time to make that decision. So start looking into it now so that you'll be ready to say yes when your opportunity comes. So thank you, everyone. Stay healthy.
Thank you, Dr. Roberts. Dr. Celestia, I'm going to come to you. Again, brief comments, then I'll go to Pastor Troy, and then lastly, Sue Kolatar.
Yes, in general, Dr. Gray, you are great. Thank you so much for facilitating this. I think we have to continue this kind of conversations in every aspect of our corner of the community. Collaboration is the current global currency. There are so many resources in Central Ohio, but we are not coordinating those services. And if we really come together as one, that's what our name Tawahedo means, coming together as one. If we come together as one, and really we have a lot of responsibilities and we can save our people. This world is enough for us, but we are not using wisely. It's just fighting for nothing. So let's collaborate and join the call to action movement. When you come together, we are very strong, and we can achieve more and effective and efficient. That's what my call really: collaboration and partnership.
Pastor Troy.
We have a saying that we try to moniker, because oftentimes when people are in church, they don't always appreciate science and medicine. And what we try to say is there's times to put feet on your prayers. And I think that's what we're challenged to do, to get to the folks who need us the most, who cannot advocate for themselves. We usually have access to those influencers. And I think the church, even though our sanctuaries may be closed, our churches are open. And to meet people where they are. We did a piece on Martin Luther King Day with the homeless community. That's new for us, but we saw tremendous needs in those kind of areas. So wherever there's a need, we've got to be willing to meet that and be the voice for the voiceless and care for folks in the way that we're commissioned to care. And I think that will be a never ending job, especially in this time. It's a great challenge to us, and we're going to see that we meet the challenge.
Dr. Kolatar.
Yeah, I think the real challenge is and hope is that we can all remain open-minded about not just facts, but the emotions that go around all of these issues, and that we continue to learn things every day and share that knowledge in an open way.
You all have heard from leading experts in our community, in health. We have a great opportunity here. You all are now armed with information to share. You all are now champions for your community, whether you're working in hospitals and nursing care centers, whether you're boots on the ground in the community, whether you're a patient, whether you're a community advocate, a community member, a learner, a scientist. Somewhere on this spectrum is you and your ability to share what you've learned today. We value your feedback too, so please give that to us. Some of our staff will be sending links, hopefully, in regards to how you can access information through OSU and see what we're doing here at the medical center. Certainly, we are a collaborating organization. We are working across sectors. You see the diversity on the panel here today, but certainly there are more organizations that are not represented on the panel today who we are leveraging or partnering with, particularly partnering with, in trying to get the message out. We can do better. And we will do better. But we thank you for being part of that solution and that part of doing better. Thank you for joining us today. We look forward to the next opportunity. Please send us your feedback, and you all be well. Have a good day.
Thanks. I'm supposed to hang up.